Well, greetings, everyone, and welcome to the EKG case for the week of November 4th, 2013. We've had a lot of great cases that are sent in by residents, and this one is no exception. Once again, a resident saves the day. This is sent in by Dr. Eric Klotz, who is a third-year resident at the York Hospital Emergency Medicine Residency Program in York, Pennsylvania. It's just above the border of Maryland, so probably about 45 minutes from Baltimore, actually. Anyway, Eric sent this case. It was an 85-year-old woman that presented with chest pain, and the 12-lead EKG is demonstrated right here. It's a left bundle branch block pattern, and so, well, we're pretty much done, right? I mean, you really can't read ischemia in the presence of a left bundle. Well, of course not. Of course that's not true. If you have not been listening to any podcasts or any videocasts thus far, you may be under that misconception, but this is our opportunity to once again talk about left bundle branch block and how sometimes you can very reliably read ischemia in the presence of a left bundle. So first of all, let's talk about what a normal left bundle branch block pattern ought to look like. This is a normal left bundle, and we talk about this thing called the rule of appropriate discordance. What does that mean? What that means is that every time the QRS complex primarily goes upwards, the J point or ST segment elevation should be a little bit below the baseline. And every time the QRS primarily goes downwards, the J point or ST segment should be a little bit above the baseline. I know my drawing's not all that good, but if you take a look at any of the 12 leads, QRS complex goes up, and so the J point is a little bit below the baseline. QRS complex goes down, and so the J point or ST segment is a little bit above the baseline. That's completely normal. Now, in some cases, it may be isoelectric, and that's perfectly fine also, but you never want to see a QRS complex go up and the ST's also up. You never want to see a QRS complex go down and the ST segment is also down in the same direction. So that's an important part of what you ought to recognize when you look at patients that have a left bundle branch block pattern. Well, this was first identified back in 1996 by a cardiologist by the name of Elena Sgarbossa. She described these rules of appropriate discordance and also the fact that if you have concordance, which essentially means that ST segments are in the same direction as the QRS, that's bad. So again, these examples up here are normal, okay? And this is sent by a good friend, Bill Brady, who obviously can draw better than me, but the QRS complex goes down, and so it's perfectly acceptable. That letter B arrow is pointing to where the J point is. It's normal for the J point to be a little bit above the baseline because the QRS goes down. When the QRS goes up, primarily, the J point ought to be a little bit below the baseline. Now, isoelectric, again, is okay. The other thing that she noticed, so this is an example, before I do the other thing that she noticed, this is an example of something that's really bad. This is called concordance. When the QRS goes up and the ST segment's in the same direction, or the QRS goes down and the ST segment or J point is in the same direction. That's called concordance, and that is a big B for bad, okay? That is highly concerning for an acute myocardial infarction. The other thing that Dr. Sgarbossa identified was something called excessive discordance. Now, if you look at figure A here, this is normal. QRS goes down. ST segment is maybe a few millimeters, 1, 2, 3 millimeters above the baseline. That's normal. But if the QRS goes down and the ST segment is, say, 5 millimeters or more above the baseline, in other words, more than 5 millimeters in the opposite direction, that's too much discordance. That's called excessive discordance. So, just to recap here, we normally want to see the ST segment in the opposite direction of the QRS by a few millimeters. But if the ST segment is in the opposite direction by more than 5 millimeters, that would be considered bad. And so we talk about the Sgarbossa criteria, which I'm listing up here, and I'm going to call these A, B, and C. What she said was that Sgarbossa A, I'm just going to use these letters, Sgarbossa A, if the ST segment is concordant or in the same direction and is elevated, so this is an example of Sgarbossa A, the QRS complex goes up and the ST segment is also elevated, that is an MI. Sgarbossa B, demonstrated right here, and she only identified this in V1, V2, and V3. So in V1, V2, or V3, the QRS complex goes down and the ST segment is down or concordant in the same direction. That would be considered bad. And then she also talked about Scarbosa criteria C, which is a QRS complex goes down and the ST goes elevated in the opposite direction. Now, normally that's okay, but if it's elevated more than 5 millimeters, okay, that's more than 5 millimeters, that's considered excessive discordance, and that would be considered bad also, okay? So there's your A, there's your B, and there's your Scarbosa C criteria. Now, what we now know based on subsequent studies, and actually based on her studies also, is that Scarbosa C is not that specific. And so a lot of people have dropped that and don't pay a whole lot of attention to that. We'll just mention it coming up in a second. But what we do know is that if somebody has Scarbosa A or Scarbosa B criteria, these are enormously, one more time, enormously predictive that your patient is having an MI. And oftentimes, most people would consider that a STEMI equivalent. In other words, if you see Scarbosa A or Scarbosa B, then just call it a STEMI and give the patient lytics or send him to the cath lab. You will be right with more than 90% accuracy, which is even better than the normal ST elevation of 1 millimeter and 2 contiguous leads that we've all learned about. You know, that's about 85% accurate. Scarbosa A and Scarbosa B in a left bundle branch block, that's more than 90% accurate. It's really, really good. Scarbosa C, not quite as good. So let's look at some examples here of Scarbosa A. This is Scarbosa A, and what you'll notice is that this patient meets Scarbosa A criteria in lead AVL. In other words, QRS complex goes up, and take a look, the ST segment or J point is elevated in the same direction of at least 1 millimeter, and in V5 and V6, the patient has 3 leads that meet Scarbosa criteria, Scarbosa A to be specific. And by the way, I didn't mention this before, in order to meet Scarbosa's criteria, you only need 1 lead. You don't need 2 contiguous leads. You only need 1 lead, and you can call it a STEMI equivalent. So this patient's EKG has actually 3 leads which demonstrate Scarbosa criteria, AVL, V5, and V6. Concordant ST elevation in the same direction as the QRS. How about Scarbosa B? Well, Scarbosa B, as you recall, is ST depression in the same direction as the QRS in either V1, V2, or V3. And in this particular EKG, V1, well, QRS goes down, there's little ST elevation. We're happy with that. V2, QRS goes down, and there's a little ST elevation, maybe isoelectric. We're okay with that, right? Scarbosa, lead V3, QRS goes down, and ST is depressed in the same direction. This patient meets Scarbosa B criteria based on lead V3 all by itself. So this would be considered a STEMI equivalent purely based on lead V3. Okay, so we've talked about Scarbosa A, we've talked about Scarbosa B. This would be Scarbosa C. You recall Scarbosa C criteria is when the QRS complex goes down and the ST segment is more than 5 millimeters, bad drawing, but whatever, more than 5 millimeters in the opposite direction. And in this particular case, probably I'd say lead V2 and probably lead V3 meet Scarbosa C criteria. And if you believed in Scarbosa C, you'd have to say that this patient has an MI based on V2 and V3. But as we said, subsequent studies have found that Scarbosa C is not as predictive, it's not as useful, it's not as specific. Therefore, a lot of people have just said, you know what, let's forget about Scarbosa C. And you can kind of imagine why. Take a look at how huge these QRS complexes are. QRS complex in V2 goes all the way down here, and so it's not surprising that the ST elevation is really, really significant in the other direction. All right? And so a lot of people have said, let's get rid of Scarbosa C. Now, let me give you a revised Scarbosa C. This was published last year in Annals of Emergency Medicine 2012 by Steve Smith, who is a really great EKG researcher from up at Hennepin. And what he said was that Scarbosa C is not that good, but what you can do is you can revise it. And what you would do is you just take the QRS complex and measure how deep is the QRS complex, how deep is that S wave, okay? And then you take a look at how tall the R wave is. So that's probably about how tall the R wave is. And if the ST elevation is at least 20% of the size of the QRS complex, then you can call that a STEMI. In this particular case, the ST segment elevation is probably about 6 millimeters. The height or the entire size of the S wave is 5, 10, 15, 20, 25, 30, 35, 40, 43. So 6 over 43 is clearly less than 20%. And so this is not, based on V2, and you could do the same thing with V3, this is not an MI. If that ratio were greater than 20%, then you could probably call this an MI. Now, let me show you another diagram. This was recently published in American Heart Journal, and other people have adopted Steve Smith's proposal. And here's a nice example. And the authors of this article said it simply has to be ST deviation in the opposite direction of the QRS. If it's more than 25%, call it a STEMI. So here's the QRS complex. It's about 10 millimeters high. Let me actually change the color here. QRS complex is about 10 millimeters high. The ST deviation is 4 millimeters. 4 over 10 is 40%. So this patient is having an MI. How about the example over here? The QRS complex from the isoelectric point is 10 millimeters, and the ST deviation is 3.2 millimeters. So this is 32%. The ST deviation is 32% of the size of the whole of the S wave. And so that's greater than 25%. And so this patient is having an MI also. Okay, so the bottom line is if the ST segment is deviated more than 25% in the opposite direction of the size of the R or S wave, in the opposite direction, then that would be very, very predictive of an MI also. And again, Steve Smith originally published this. This has been supported by this article in American Heart Journal, which, by the way, this article has Sgarbossa as, I think, the third author in this study. Now, the one caveat I'm going to give you about this revised Sgarbossa C criteria is that it has not yet been validated. So I'm not going to push this. I'm waiting for somebody to validate it, and as soon as somebody validates it, we'll talk all about it. But for now, Sgarbossa A and Sgarbossa B are definitely validated, and this revised Sgarbossa C hopefully will be validated, and we can adopt that as well. So in this American Heart Journal article, this is a very nice algorithm to follow when you're looking at a left bundle branch block. So if you have a patient who's got concerning symptoms and they come in with a left bundle branch block, if they're hemodynamically unstable or in acute heart failure, you're done. That patient goes right for cath or gets thrombolytics. All right. If they're not unstable, the next thing you do is you look at the EKG, and let's get rid of the score right here because that just confuses things. If they have Sgarbossa A or if they have Sgarbossa B, you are done. That patient goes for cath or gets thrombolytics. All right. So Sgarbossa A or B, we're done. That patient is an STEMI equivalent. If the patient doesn't have Sgarbossa A or Sgarbossa B, then you go and you look at that ratio that we talked about on this slide. And if that ratio is more than 25%, then what they're proposing is that if that ratio is more than 25%, then you can call it an MI. Give them lytics or send them to the cath lab. And if they don't meet any of these criteria, then just go ahead and rule them out the way you do normally with anyone else that has a non-diagnostic 12-lead EKG. All right. So this is just a proposal. It has not been validated yet. I would say that this has clearly been validated, and also I would say that there's enough data to say that this ought to go for cath or lytics as well. All right. So if they're unstable or acute heart failure, or if they have Sgarbossa A or B, you're done. That patient could go for cath or get lytics. All right, and by the way, we've kind of mentioned this before. New left bundle branch block is no longer a criteria. They have to be unstable or have to have Sgarbossa A or B in order to qualify for cath. Just a plain old new left bundle, big deal. All right, nobody cares anymore. All right, so going back to Eric's 12-lead EKG, 85-year-old woman with chest pain. When you look at this 12-lead EKG, remember what the Sgarbossa A criteria are. If you have QRS complex going up and there's ST segment elevated of at least a millimeter in the same direction, this patient has Sgarbossa A criteria in lead 1, Sgarbossa A criteria in lead AVL. Remember what Sgarbossa B is? QRS goes down and the ST segment is depressed in the same direction. This patient has Scarbosa B criteria in V3. So this person's got both Scarbosa A and B on the same 12-lead EKG. I don't see any leads that have that revised criteria, but who cares? This person's got Scarbosa A and Scarbosa B. This patient definitely is having a myocardial infarction. You could call this a STEMI equivalent, give the patient lytics, or send him to the cath lab. As it turned out, even though this patient was diagnosed with an MI in the presence of a left bundle, the patient had a bad outcome, unfortunately. But we can nevertheless learn from this case. All right, so quick take-home points. Remember, Scarbosa A. Scarbosa A, if somebody has concordant ST segment elevation, that is an MI. Scarbosa B, if somebody has concordant ST depression in V1, V2, or V3, that's an MI. And then the revised Scarbosa C, hopefully there's going to be some validation studies, and I'll be able to eliminate these question marks. If there is discordance of the ST segment, and the discordant segment is at least 25% of the size of the R or the S wave, then Steve Smith and these other authors have proposed that that is an MI, and the data looks pretty good for that, but we're going to have to wait on the validation studies before we start really pushing our cardiologists in that direction. I think if Steve Smith probably is pushing his cardiologists already, but your cardiologists probably don't know about that literature, and so you may have to hand them that literature on a silver platter so that they will adopt it as well. All right, so hope that was helpful, and remember, you can read MI in the presence of a left bundle branch block pattern. You've got to know Scarbosa A, you've got to know Scarbosa B, and you've got to be on the lookout for future studies on the revised Scarbosa C. Thank you to Steve Smith for publishing that really, really helpful information. All right. Hope that was helpful, and I look forward to talking to all of you next week. Bye for now.